Okay, great. It's a real honor to be here at the 20th anniversary of this meeting and to see so many patients here today. I'm delighted to be able to speak to you. So I'm going to kind of talk a little bit about some different things here. And I'm actually, when Amy and I were talking about what to discuss, I said, well, maybe I'll show some videos and actually show you what happens when the lights go off. And so I actually have quite a few videos for you today to show you really all the advances that we've made in the past, 20 or so years. And everything I'm going to show you is something that we do here right now. And I have had, I'm honored to follow both Dr. Donahue and Dr. Tempero, both who I've had as colleagues because I used to work at UCSF many years ago. And we actually are still doing research with UCSF, which I'll talk about in a minute. So I'll get started. Some disclosures. So I'm going to talk today initially about pancreatic cysts. We'll talk a little bit about how common they are and the general types of cysts. And I've spoken in this forum to you about that before, but I'm going to focus primarily on the role of endoscopy today on diagnosis and treatment. And then I'm going to talk about pancreatic cancer. Tim had mentioned, and I think you'd heard about sort of new ways to treat pancreatic cancer, and some of the potential ways to help with the immunogenic response may include some endoscopic treatments, including radiofrequency ablation, and there are many that are being proposed, but I will talk to you briefly about that, some work that's being done there. And then I'll talk about some of the advances that we have to improve quality of life, and in terms of finding ways to relieve jaundice. A lot of times when we're not able to drain an obstructed bile duct internally, we have to do percutaneous drains through interventional radiology, and that's not ideal. You've got this thing sticking out of you, you've got this bag you have to keep draining. There are sometimes surgical techniques that are needed to relieve bowel blockages. But we've actually come up with some very novel ways to manage that now endoscopically. And there are even ways to treat your pain when you have pancreatic cancer so that you don't need so much in the way of narcotics and all the side effects that are associated with that. And so I'm going to kind of show you some of those things. So let's talk about pancreatic cysts. So these are the main types of pancreatic cysts that are there. The most common ones are probably the side branch IPMNs. These are the ones that are probably seen most commonly incidentally. There are these when the main pancreas duct, which is sort of the river that drains the pancreas here, is dilated. That's either a main duct or a mixed type IPMN, and those tend to carry a higher risk, and those are typically things that we treat surgically. There are also these mucinous cyst adenomas or mucinous cystic neoplasms, and those also carry some malignant potential. And it's really the mucinous cysts that are here that we try to separate from the either inflammatory benign or the serous cysts, which are generally considered benign. There's a rare type of cyst here called the solid pseudopapillary neoplasm, which carries a low risk, but it's usually present in young women and usually ends up getting resected as well. So how common are pancreatic cysts? It turns out they're super common. So these are just radiologic series. If you just take a look at, if you were to happen to get a scan of your belly, what's the likelihood? And the chances probably as low as 1 in 40 or as high as 1 in 3. And I would argue that over time, as our imaging has gotten better, it's actually closer to the latter. So overall, around 15% of people are going to have a cyst when they get a scan. But the good news is that the risk of cancer at the time of imaging is quite low. It's about 1 in 400. So you shouldn't, necessarily worry too much. It does increase with age. These are 3 different studies showing that across the board, the cysts increase with age. And a few years ago, one of our fellows and I looked at every single MRI that was done at UCLA Health in 2018, and I actually use this a lot in my clinic. If you're 50, there's about a 1 in 5 chance you'll have a cyst. If you're 60, about 1 in 4, 70, 1 in 3, and if you're 80, it's 1 in 2. And so it's quite common. Most of these cysts are less than 10 millimeters, about 2/3. The remaining third are between 1 and 3 centimeters, and then very few are at this high-risk group that are more than 30 millimeters. So again, as I mentioned, the risk of cancer, all cysts, is probably on a per-year basis very low. It's like 1 in 400. Even if you have that mucinous type, the type I told you that could turn cancerous, it's still under 1%. It's about 1 in 125. But of course, the problem is that there's so many people with these cysts, and you have many years. Some of these people are in their 50s, they have 30 years. And so that's why the risk is. And that's where, I'll come back to this, we really need better tools to predict cyst behavior once we know they have a mucinous cyst. But the first thing is, as I told you, there's a whole bunch of different types of cysts. Some are totally benign, and if we were 100% sure if it was that type of cyst, we wouldn't even follow you. But other cysts, of course, do require follow-up. But the problem is it's very challenging to figure out exactly what type of cyst you have. Endoscopic ultrasound was sort of alluded to in both of the prior two talks, and again, that's where we have the scope that has a camera, which not only can allow you to look at the inside of your GI tract, but also has an ultrasound built in it that can look through the back wall of the stomach, which allows us beautiful views of the pancreas. But even that high-level imaging alone, as you can see on the left here, that cyst could be still one of several things. And so imaging, unfortunately, alone, so that's kind of my point number one, is imaging alone can suggest, but it's not confirmatory. So then what's the advantage of ultrasound is we can stick a needle into the cyst, get fluid and cells, and sometimes that can help us make a diagnosis, and I'll kind of show you some of the techniques. So here we have a bright needle kind of in here. Here we have a little, probably a mucin ball here. Here there's another small area here, which could be mucin or a small nodule. So what can an endoscopic ultrasound do? I mean, you heard that we could do MRI or we could do endoscopic ultrasound. The main advantage is that, again, we can aspirate, we can get fluid, we can look for mucin, we can biopsy a nodule, we can also get careful evaluation of a cyst and its relationship to the blood vessels, the main pancreas duct, to help Dr. Donahue and his colleagues determine resectability. And it can also help us look at the rest of the pancreas to get a sense if there's underlying inflammation, because sometimes if there's a lot of inflammation, it may suggest that maybe this is actually an inflammatory cyst and not a neoplastic cyst. But as I said, imaging alone is not enough. So if that's the case, then what are we going to do with the material that we obtain from a needle puncture? Well, we could take that fluid, we could suck it up, we could spin it and sort of take a look at the cells, and that's called cytology. Unfortunately, you don't get a ton of cells doing that, and so as a result, it usually isn't very sensitive, meaning that only 20 or maybe 30 or maybe 40% of the time do you get an answer, even if there was a cancer or precancer there. We then also use the fluid for other testing. We can run several markers. CEA is one of the markers. You can check for amylase, which is the enzyme in pancreas juice that helps digest some of our food. And of course, you could just run glucose. And then you heard about KRAS earlier in Dr. Donahue's talk. You can look for genetic mutations as well. But unfortunately, this is the area where I feel like even though we've spent about 15 years working on this, we still don't really have good molecular tests. In fact, one of the companies that runs it actually is kind of out of business right now with regards to that test because we just don't have good predictors. So my second kind of key point that I'd like to leave you with is we've gotten a lot better at diagnosing cysts, which I'll get to in a minute, but we still don't have a good sense if we do have a premalignant cyst about how they're going to behave. So we need help on prediction, but we've improved on diagnosis. We can do this generally safely when we took the needle in, 1 to 3% risk of inflammation, very limited bleeding, usually low risk of infection. So this is a famous study from 20 years ago, and they said, well, let's get this needle in this cyst, we'll take some fluid, let's take a look and see what we find. And they found out that the CEA was a lot higher in the mucinous cysts on the left than it was on the inflammatory and benign cysts on the right. And so they said, well, gee, maybe we could use that as a number. And so then they kind of created this scale where you say, okay, where's kind of the sweet spot where we get the best performance for the test? And they said, well, yeah, this 192 seems to be a good number where we can distinguish between, but again, none of this is perfect. So if you get a 180, that doesn't mean you're not mucinous, and if it doesn't mean you're 200, you are. So again, it's a little bit of take it with a grain of salt. But again, this is also not going to be able to tell you whether it's cancer or not. It just tells you whether you likely have one of those mucinous cysts which have cancerous potential. So when we do this procedure, when you come to see me for a procedure and I aspirate your cyst, I'm going to usually look at the viscosity to see if it's thin or thick. Mucinous cysts are thicker. I'm going to run the CEA, which will usually tell me if it's high, that you may have either an MCN or one of those IPMNs. Those are the precancerous potential. If it's low, it's probably inflammatory or a benign cyst. And again, if it connects to the main pancreas duct, it'll have a high amylase, and if it doesn't, it won't. One of the newest tests, in fact, to cut to the chase, the one I actually trust the most now, is glucose. And it turns out it's a simple test. It's a lot cheaper. There's several studies suggest you could take the fluid and even stick it on a glucometer strip and actually get results that are pretty good. And when you compare the performance of glucose to the CEA, at least in this early study from about 10 years ago, it suggested they were pretty similar. And in fact, then this got a lot of people excited, and there's been a lot of studies that have been done. This original work was done at Stanford, but it's now been sort of verified at multiple places. And so over 600 patients now, you can see that the overall accuracy of predicting mucinous versus not with glucose is 94%. For CEA, it's only 85%. And so you might say, well, gee, if you've got these two tests, maybe putting them together would be better than one of them alone. It turns out, no, the glucose doesn't really need the CEA. Adding the CEA to the glucose didn't do better than the glucose alone. So it's like anything. If it's good to get as many sources of information as possible. So if you're saying, oh, gee, do you only run glucose now? No, I run all the stuff. But when I get sort of conflicting results, I tend to go the direction the glucose leads me. So in terms of, well, the next thing is, well, that's nice. These are sort of fluid and numbers, but, in medicine we often say tissue is the issue, right? So why don't you try to just get me the actual answer with cells? And that can sometimes be difficult. As I told you, spinning down the cells from it, there's often not a lot of cells. And if you take a look at this is what I was alluding to earlier, only about 50 to 60% of the time can we make a diagnosis using that. When we do make the diagnosis, it's usually right. So in other words, if we say that there's some abnormality there, it's probably correct. But so the positive predictive value is good, but overall we still miss a lot of them because we can't get enough cells. So then that leads to the question, well, how do we get better at getting cells? And so this is somebody said, well, why don't maybe we'll put a brush. So instead of just sucking the fluid, we can get the needle, we'll put a brush and we'll rub it against the lining of the cyst. And so this was quite popular, at least initially as a concept in the late 2000s, but there was some significant bleeding in a couple of these cases. And then a larger study found out that even though it sounds like a good concept, it really wasn't better than just aspirating the fluid and spinning it down anyways. So at that point, it's like, okay, it may be more risky. It doesn't seem to be any better. And so the brush concept sort of died. So then the next concept was, well, okay, let's take a needle and then let's put a forceps through there so we could actually take a pinch biopsy, similar to the way when you get an endoscopy or a colonoscopy. And so that exists. So this is a larger needle, which makes it a little bit technically more difficult to do. But you can see that through this needle, there's a forceps, and you can actually get, rather than sort of just individual cells, you can actually get tissue with this microforceps. Now, this combination is a little bit expensive. It's about 3 or 4 times the standard needle, but it did perform better. You can see that it was able to, they tried 114 patients. They had 20 where they failed, but in the 95 they were successful with, they were able to get an answer in 75 of them as to what type of cyst it was. And in the 14 that went to surgery, all of those had the same answer that the biopsy said it was. So about 1 in 20 got pancreatitis. There was a little bit of bleeding, so it's not without some risk for it, but it definitely was better than what we'd been able to do. So again, there's been several studies that have subsequently looked at this, and overall it seems that about 80% of the time they can get a diagnosis, and that's really the main thing I want you to take away from this. So, as I said, the price of sort of that combination is about 4 times what a regular needle was, and as was being alluded to in terms of precision medicine, and some of the tests that are being done, we've developed better and better needles that now allow us, when we make a diagnosis of cancer, not only to just get a few cells, but to actually get tissue and architecture. And in some of these cases, that can be even used to develop microtumor models to predict chemotherapeutic response. So as these big needles sort of came out, which are really being diagnosed to diagnose solid pancreatic cancer, I started wondering, well, gee, I wonder if I could use this to biopsy the cyst wall to try to get a better answer for the cysts. And so we wrote a paper, which is still the largest series on this that's been published to date, looking at EUS cyst aspiration. So I'll show you a video of this. So when you come to see me for a pancreas cyst aspiration, if I'm very concerned about what we're dealing with, I can aspirate the cyst, collapse the cyst, and then sort of biopsy the flattened cyst with this core needle, and it turned out we were able to get a diagnostic answer 86% of the time, and unlike the other sort of system where they had 20% of the time they couldn't get the tissue, essentially we were technically successful in all cases. So I'll give you an example. This was a 28-year-old woman from Las Vegas, no personal or family history of disease. She came in with unusual 2.7 centimeter cyst at age 28. She had had an aspiration in Las Vegas. It had a low amylase. The CEA was low, which is good, suggesting non-mucinous. But she was very anxious about this. She wanted to start a family, and she felt this was a big cloud over her head. And she actually told me, if you can't give me a definitive diagnosis as to what type of cyst it is, I'm having a surgery to get rid of this before I try to get pregnant. So I said, okay, well, let me take a look. So I did her endoscopic ultrasound, and then we started here. And I'm going to show you the technique that we published again. So basically, we just take the needle. It's not that different than usual. We're going to put, there's the cyst there in the black here. Oops, sorry. Let me go back. Can we restart that? There we go. Hit the wrong button. So here's the needle here. Here's the cyst. And so we're going to go into here, and what we're going to do is you'll see this black cyst sort of in a moment. You're going to see a bright white line in there. And there's the tip of the needle now. And then this area, this sort of cyst is going to start collapsing because we're aspirating the fluid. And as it gets smaller and it collapses, then we'll biopsy back and forth across the wall. And it turned out this did the trick. So we actually, to my surprise, I did not think this looked like it, but it turned out it was one of those benign cysts. It was a serous cystadenoma. She was delighted that she had a benign cyst. And then about 18 months later, I got a picture of her new baby boy, which was a nice sort of touch. So again, we can get definitive answers. Here's a couple of other cysts. You can see this is right out of our medical record. It says serous cystadenoma. There's no guesswork here. This is the answer. And again, here's another one, low-grade IPMN. So we're trying to take the guesswork out, and we're trying to, and I think increasingly, and what's really nice is for the benign cysts, because studies have shown that even in expert centers, Massachusetts General Hospital, many surgical centers, between 20 and 30% of resected cysts are benign, and we're trying to do better in doing that. As I mentioned, the molecular analysis has remained a challenge. It's been around for 15 or 20 years. They've looked at KRAS, they've looked at DNA count, but when you look at it compared to our existing guidelines or comparing it to just our usual markers, several studies have shown it doesn't really seem to add very much, and I've always been somewhat confused with the results. It's somewhat expensive as well and isn't always covered by insurance. So this is a real opportunity. There's no question I'd love to be able to better predict if you had a mucinous cyst, what your level of risk was over 5 or 10 years. And I hope that, at the 30th anniversary of this meeting, we'll maybe be able to give you better results on that. What about ERCP? These are a couple of cases that I've shared with Dr. Donahue. On the right is one of those main duct IPMNs where we were trying to figure out exactly how much of the pancreas was involved prior to surgery. And you can see the tumors part here on the bottom right there. And so this can help sometimes preoperatively map exactly how much pancreas we need to remove or not remove, which can have important consequences, obviously, in terms of diabetes after the procedure and so forth. On the left is a patient that Tim and I evaluated, I think, 13 years ago. This was a patient who I was pretty convinced only had a side branch IPMN, but the main pancreas duct was dilated at the level of where that entered the main duct. And so it did look like a mixed type, which is something that you typically operate on. And so I asked him to give me a chance to look inside the pancreas duct and see if I saw any debris or any material or growth in there, or if this was just mucin from a side branch that was masquerading as a mixed type. And so he was kind enough to give me a shot. And so here we are on the left there. I've got a camera well into the pancreas. And so you'll see seeing the images here in a moment. And so here we are inside the pancreas duct, and what we found was a pretty normal appearing pancreas duct. You see this hazy sort of cloudy stuff, which is all the mucin that's inside the pancreas duct. And if you'll see here in a moment, there's a big opening on the side, which is where that mucin is coming out of. So this is kind of glue coming in from a small river into a big river, causing upstream dilation. This is a little bit of a false alarm, and Tim was in agreement that we could perhaps watch this patient rather than operate. Pancreatic cyst, in terms of EUS for treatment, we actually have some techniques that have been available. So you can aspirate the cyst, lavage it with alcohol to kill sort of the lining cells, and then inject it with a chemotherapeutic agent, paclitaxel. And this has been done in small series, 6 different publications, showing that between a third to maybe even 75% or so of these cysts can undergo complete eradication at short-term follow-up. The problem is that we know these patients are also at risk for solid pancreas tumor, and so complete resolution of these cysts still doesn't prevent them from needing continued surveillance and observation. And so, sometimes people say, well, just get rid of my cyst and I just want to walk away. And unfortunately, it's not that simple. They're still at increased risk. Here's a study from Asia, again, showing in a large group of patients, 164, of which 114 completed treatment. They were able to 114 successfully eradicated. So 3/4 of the patients in this Asian study got rid of all their cysts. And then now there's some recent studies suggesting that we don't really even need to lavage with the alcohol. We probably just mostly need the chemotherapeutic, which seems to work as well and reduce the complications. In the last probably 7 or 8 minutes here, I'm going to talk about pancreas cancer and treatment options. You've heard, you obviously know about chemotherapy, radiation, and surgery. There's obviously immunotherapy, again, when Tim kind of talked a little bit about some of the challenges. But I would argue now we're starting to also get EUS-guided therapy, and there's actually about 9 different ways that this can be delivered. I'm only going to talk about one of them right now, and I'm only going to briefly talk about it. You could do a full hour lecture on radiofrequency ablation. But this is some work that, and these are some slides that are courtesy of Dr. Muthusamy, who's actually in Houston, who's pioneered a lot of this. And so during this procedure, they undergo chemotherapy, but also about once a month, they undergo an EUS procedure where they actually undergo ablation of the tumor as well as part of their treatment, and then they're sort of evaluated after several cycles, and then potentially, hopefully, are downstage to the point where they get surgery. So you want to avoid being too close to the pancreas duct or large blood vessels or the wall, but you can actually create a nice little zone of ablation where you can actually treat areas that are 15 by 9 millimeters, depending on the size of the needle. And I'll show you a video of this here. So you see a small neuroendocrine tumor here, and you can use this as for pancreas adenocarcinoma, but you can also use this as primary therapy. We do this at UCLA. I've done this on quite a few patients now with renal cell cancer metastases to the pancreas, but you could also perhaps even use this as a treatment for certain neuroendocrine tumors in patients who maybe poor surgical candidates or choose not to do so. And as you do the heating here, what you'll notice is you can actually tell which parts are treated, because you'll see this whiteness here. You see how this is starting to turn white? That's the area, as it heats, it sort of dries up and it changes in its echo characteristics. And so you can tell which areas have been treated successfully. So this is another technique that we've been using. Nirav's got several studies that are going on, but this is actually a study from Thailand showing that using this in patients with pancreas cancers 4 centimeters or smaller that were unresectable, they could achieve about a 6-month increase in survival using this as an adjunct. Interestingly also, it's unclear how this may help. They feel like it may help activate the adaptive immune system. And they've seen even what we call this abscopal effect, where even though you're treating a primary lesion, you may see benefits in areas that were not directly treated, such as metastases. So again, it's very early on in this, and I think there's many, many unanswered questions, but I think there's some promise. So in the last couple of minutes, I'll talk about some techniques we have to help you if you do have obstruction. And in the past, if we couldn't get in with the standard ERCP, you'd often have to get a percutaneous drain. This is a series of patients I worked on when I was at UC Irvine, where we showed that with ultrasound, we could actually enter the bile duct indirectly. We could create a different track, inject, put a wire down, find it the normal opening, and then subsequently stent it that way. And we were able to, 3/4 of patients who had previously had a failed drainage internally, we were able to internalize and avoid a percutaneous drain. Here's another example of how this could be done. I had a little trouble with this video, so I literally just a few minutes ago took this with my iPhone on my computer and then translated it here. But this is now taking, this is a patient who also could not get an ERCP because there's tumor, as you can see on the top left, infiltrating the duodenum. So we're actually going through the stomach, into the liver, into a dilated duct. We're shooting contrast. You can see where this is inside the liver here. We've got a wire. We're trying to get across the tumor, but we couldn't, and so we ended up actually putting a stent into the stomach. This is called a hepatojejunostomy. There's another technique that's now actually become more popular. This has actually got approval in Europe. I think it will soon have it in the United States. I will mention this is off-label right now. But we can actually access the bile duct directly with this new dumbbell-shaped stent, which was actually developed by a gastroenterologist in San Francisco. And then we can pull this back and we can drain this. And there's lots of studies that have shown now that this has similar technical adverse events and it's much faster. You can actually see we're looking up the bile duct here. And so the idea is that we're trying to drain these at one session, not have a failed procedure, not have a subsequent interventional radiology procedure, and I think we're able to do that. Again, this is not FDA approved for this. This is a randomized trial from Asia showing that the technical success rate was 20% higher when you use this technique, and the procedure time was 60% shorter. So this is, again, another. And I'll close by talking a little bit about duodenal stenting. This is using that same stent now instead to create a tract between the stomach and the small bowel when pancreatic cancer blocks the duodenum. Here is a patient who had an obstruction here. I'll show you this before lunch. Dr. Tempera was concerned that I was showing this, but I figured you'd want to see this. So anyways, here's a patient, total blockage, can't eat at all. We get a wire down. We put a little tube in. We're going to inflate with water. The beauty is that this normally used to be a surgical procedure that we've now gotten into a 20-minute endoscopic procedure. You can see the small bowel, which is next to the stomach. And what we're going to do is use that same lumen-opposing stent to create that dumbbell bridge, to create an alternate way for this patient to eat. There are lots of studies now. This is also not FDA approved yet, but there's such a huge body of evidence for this now that I expect to have FDA approval within the year. And again, you're going to see the needle pop into the small bowel, the flange opens, this dumbbell, we open the other dumbbell, and you'll see the colored dye that we use to make sure that we're in the right limb, and you'll see that nice passage here in just a moment. Voila, there we go. So now you've got the drainage here, and so we've just done an endoscopic gastrojejunostomy. So again, these are ways that we can help. We can. These are some of the studies which I'll just show that this is very effective relative to surgery and our standard duodenal stenting. And here's a randomized trial compared to surgery, showing this technique had fewer reinterventions, more rapid diet advancement, shorter procedure time, and shorter hospital stays. We can also inject celiac ganglia to relieve pain from pancreatic cancer, and this is a technique that's been described for many years. And if you can find actual ganglia, sometimes we can actually see the nerves and inject them, you're 15 times more likely to get pain relief. So in closing, pancreatic cysts are extremely common and increase with age. Their overall risk of turning in cancer is low. EUS can help characterize the cysts via fluid analysis and cytology and histology, but imaging alone is insufficient. Pancreatoscopy can help in select cases where you have these main duct IPMNs. We need better molecular prediction tools so that if you do have one of these precancerous IPMNs, we have a better way to stratify how often we follow you and watch you. We do have the ability to ablate, but again, it's still investigational. Many patients will still require follow-up. I will mention RFA is now being used for cyst ablation as well, in addition to treating pancreatic cancer in PNETs. And again, I showed you several palliation techniques for biliary and duodenal obstruction and pain that can avoid the need for additional procedures or excessive narcotics. Thank you. Take any questions?
Hello. Hi.
Hi.
I have pancreatic cysts, and I think they're still small because they've never given me actual dimensions for it. But at what point would someone like me come to see someone like you, a specialist like you?
Yeah, I mean, I think you could certainly always, have a consultation to discuss management. I think most of the time, when you have a pancreas cyst, we're going to follow you with non-invasive radiologic imaging, typically an MRI to avoid frequent radiation. And that typically is at 1 to 2 year intervals. And then after a long period of stability, you could either do it even less often or even consider stopping. The reason to do the endoscopic ultrasound and do all the stuff that I was talking about, usually if you have one or more high-risk criteria, which is a cyst more than 30 millimeters, a pancreas duct that's dilated to at least 5 and sometimes 10 millimeters, or if there's a nodule within the cyst. So if you have any of those three, then we would definitely be interested. Or the other thing is if there's rapid growth, usually 2.5 to 3 millimeters in a year on imaging, sometimes that might be another reason to do it as well. So those are the reasons. But I see many patients with small cysts just to give them a long-term plan, but it never hurts to have a discussion.
And can my regular GI just kind of monitor that?
Yeah, sometimes if they're comfortable. I mean, there are general guidelines on this, and usually the patients I see are the ones that usually have one or more of those higher risk features who are being considered for an endoscopic evaluation.
Okay, thank you.
Mm-hmm.
Hi, Dr. Muthusamy.
Hey.
So 2 generations of pancreatic cancer, my paternal grandfather and my father, and so we pretty much do everything you've been talking about. And what I was going to ask you is when I come in for my endoscopic ultrasound, if you were to find a cyst of some sort during that, would you do anything at that time, or would I have to come in for another?
Oh, when you're getting an EUS, for example, would you?
Yeah.
Yeah, if we felt it warranted it, right? So if it was an 8 millimeter cyst, it's probably so small I may not be able to get enough fluid to run those tests and isn't really needed. So I think that would be based on the size of the cyst, the characteristics of the cyst, other features. But yeah, if we incidentally run into, and in fact, Dr. Napiro was talking about screening for pancreas cancer. Traditionally we've done that with MRI and EUS, and the most common finding that we usually see on EUS on patients undergoing screening is the incidental cyst. And so in many of those cases, we may sample that depending on some of those criteria.
Thank you.
Mm-hmm. Okay.
Yes, I had one follow-up question.
Yeah.
I don't think I've heard of the glial kind of pain, a way of addressing pain through the glial nerve cells there. In what situation would that really apply in our family? The patient's been taking like 15 milligrams of morphine multiple times a day.
Yeah, so that's the celiac nerve. And so there's a couple of different ways. There's the radiologists sometimes can do it too, but they kind of do it in I think a little bit more risky way and a little less precise way. We can do it fairly accurately. But it seems to work better for cancer than chronic pancreatitis. But those nerves are responsible for innervation of a lot of the upper abdomen, including the pancreas. And so, if you've got a patient, and it also seems to work better earlier in the diagnosis. And so, if a patient is having a lot of pain and they're getting a new diagnosis of pancreas cancer, especially if their pain initially isn't quickly respond to narcotics, or if they're having side effects from narcotics, really it should be considered for treatment with that, because they may get significant relief or at least be able to reduce their narcotics substantially and get less side effects.
And would that be a one-time procedure?
Yeah, great question. It can be repeated, so especially if it was effective. There sometimes can be worn off, and so I have done repeated treatments, in some patients as needed.
And is that just here at UCLA, or are there other?
That's pretty standard. I would think most cancer centers would have endoscopy options that would include that.
Thank you so much.
You bet.
Can you address the age of the cysts, despite growing and size, and how many as a factor?
Yeah, I mean, I think usually, that comes up a lot. Is it better to have, which is worse, one 15 millimeter cyst or 3 5 millimeter cysts? And I think that usually it's the size of the largest cyst that we think portends the greatest risk. It's not clear. The longer that you've had a cyst without progression, I think that generally portends a better diagnosis. But, I have seen some patients, I'm sure we all have, that were fairly stable for a period of time and then suddenly underwent a transformation. So that's part of the reason why some of us are uncomfortable stopping surveillance, like one of the guidelines suggests, with stability at 5 years, because I've definitely seen cysts that behaved for 5 years and then grew. So, okay. All right. Thank you so much.